going to get started. Welcome, everyone. My name is Danielle Angelari. I'm the Executive Director of NAMI Northern Illinois, which is an affiliate of the National Alliance on Mental Illness. And we are a part of the nation's largest grassroots mental health advocacy organization dedicated to building better lives for people living with mental illness and their families. Tonight, we're going to be talking about eating disorders, which are complex mental health conditions that have serious physical and psychological consequences. They are characterized by abnormal eating habits and attitudes towards food, weight, and body shape. These disorders can affect people of all ages, genders, and backgrounds. Early detection and treatment are crucial for recovery and may involve a combination of treatment modalities. Here to discuss this topic is Dr. Erin Terada. She is a licensed clinical psychologist and the director of clinical training at Relief Mental Health. Highly regarded by her peers, she has decades of experience in treating feeding and eating disorders, anxiety disorders, obsessive compulsive disorders, and trauma disorders. She has practiced in multiple treatment settings throughout the greater Chicagoland area and expanding.
Mhm.
I would like to ask if we could reserve all the questions for the end, and then we will use the Q&A feature.
All
Thank
right.
you.
I think that's my cue to take it away. So I'm going to share my screen and we will get started. All right. So let's see if we can. All right. So I'm going to put this to the side a little bit. All right. Now, again, I'm Dr. Erin Terada. This is about understanding how to support a loved one struggle with food and their body. The way that I designed this talk is really to be able to give not only parents, but any clinicians who are watching, anybody who is supporting somebody who they think may have an eating disorder, just generally, how do we understand them? Why is it important to do so? And what are the things that we need to look out for in general in terms of what we can do to just initialize that support, and or when it gets to the place where we need to do something more, when do we do something more? So we're going to go over a lot of stuff. I hope you can get at least something out of it. If it is a direction to go in, if it's a little bit more knowledge about the seriousness of these disorders, or all of the above. So let's kind of dig in. I first want to kind of get you guys familiar with Relief Mental Health. So I'm the Director of Clinical Training at Relief Mental Health. Our outpatient provider, we are an outpatient provider, I would say, of transcranial magnetic stimulation for the treatment of depression, OCD, anxious mixed depression presentations, as well as for TMS can be used for smoking and addiction issues. We also provide psychedelic therapy with Spravato, which is a nasal ketamine spray. This is used for treatment-resistant depression, major depressive disorder with suicidal thoughts or behaviors. That is approved for adults through the FDA. We also provide IV ketamine treatment for a variety of other mental health diagnoses, traditional psychiatric services such as medication management and psychotherapy, which is one of the things that I specialize in. We opened in January of 2020 and we are still going strong. Our main hub is in Oak Brook, Illinois, but we have 10 locations throughout 3 states, and one of those is in Rockford, Illinois. So we're glad to kind of be here again and be a part of, sort of giving out the messages of what we can do and in certain eating disorder categories to NAMI out of Rockford. So let's get started. Today, here's what I want to be able to give you guys some objectives and understanding in, and I hope I'm successful in doing at least some of those. One, I'm going to teach you about the criteria for the most common eating disorder diagnoses and how they develop. We're going to do a quick overview, not a really scientific one, but I'm going to give you some really pointed tips about why this is important and what we look out for when we are looking at an actual eating disorder diagnosis. I really want to kind of go over more, though, understanding the warning signs of eating disorders, negative body image development, as well as when to seek professional help. Signs to look out for, how to prevent and support are going to be the last things, including how to improve the home environment to promote overall better connection with food and body image for everybody, especially when somebody we know is struggling. So let's get into it. First, I usually like to go over stats. So what we do know is that regardless of whether you think, it happens, this starts early. That means we can intervene early and we can prevent this in many ways. So for instance, recently the stats are, coming out that by age 6, girls especially want to start to express concerns about their own weight or body shape. As young as 6 years old. A third of boys and majority of girls from 6 to more like 8 years old express a desire to want to be thinner or be on a diet by the time they get to that 8-year-old mark. And that gets even more so by 78% 10-year-old girls, when polled in surveys, have tried dieting at least once to lose weight. Again, we don't have numbers on boys because we just don't have that much aggregate data on how boys do go about this, because it has only been recently something that we've started to really look into how boys and men and their shape of an eating disorder or body dysmorphia and all those things tend to happen. So what we do know right now from the data that we're getting is that one half of teenage girls and one third of teenage boys, so about the same, use unhealthy weight control behaviors such as skipping meals, fasting, smoking cigarettes, vomiting, or taking laxatives and other things. And what we would consider this is actually the start of subclinical disordered eating signs that somebody could develop into riskier behaviors or are trying to do something to manipulate their weight to make themselves feel better, either about their body image or self-appraisal. So when we're seeing, a cluster of these symptoms, especially with food and body and changing our relationship with both, it starts in one place, either with thoughts or concern about body image and not liking how you look, but then can start morphing into these other places. The reason why we look at this so intently, and again, I'm an eating disorder specialist. I'm a certified eating disorder specialist through IDEP, and I've been doing this for years. But the thing that always strikes me is how many people outside of that, in the clinical world and in just the general common knowledge, is that eating disorders are, resulting in a lot of people having very, very difficult medical issues, physical health effects, and other things that they cannot reverse even after they occur. They are affected by this for life. And for many people who have an eating disorder or an eating or feeding disorder, they often can create problems for life that will end up affecting them way down the road, that they're doing when they are 11, 12, 13, 16, 18, that can really have a very large effect on how their life turns out and how they're physically able to function throughout their lifetime. These are often secret in sort of the way that they are, done. So eating disorders are not something that people often feel very proud of it. They are very shameful in many ways. They are also compulsive. So there's a lot of guilt and sort of why did I do that again kind of things. They also don't occur in isolation. So there usually is another mental health issue such as depression, anxiety, substance abuse, OCD, all those things even combined that can lead somebody to developing a way to cope with the effects. So we know that there is a co-occurrence in a lot of these things. And lastly, even though they can have some long-term effects on physical health, they are also deadly. This category of behaviors or disorders in the DSM, it is the one category of mental health disorders that has the highest direct mortality rate related to engaging in the disorder. So this is not like substance abuse. This is actually the one that has the highest direct rate because the disorder creates a physical effect that cannot be reversed and can kill you. So the way that I kind of explain people the statistic is down below, that this still holds up, that 1 out of 5 before the age of 25 die if they have a severe and chronic eating disorder that has been diagnosed due to the medical complications related to engaging in the eating disorder behaviors. And it's non-discriminatory across the board. 1 out of 5 before the age of 25 who are actively and severely engaging. And it doesn't take long. So this is why I love talking about these things and talking in spaces like this, that we need to be serious about this. And there's a lot of early prevention and things that we can do to make sure that this doesn't happen to another kid. So when we talk about eating disorders, what I want to be able to impart is this, is that there is the general population. There is on the, left, people who have normal discomfort or dissatisfaction in their body, They're able to kind of weather that storm if they feel like they're just not feeling that they have really good self-esteem, things like that. But they generally can accept their body and how it looks and the ways that it does what it does for them in the world. And then we get into that disordered, oops, let's go back to that disordered eating category. The disordered eating or unhealthy relationship with food or body category is where we would call that subclinical. So the general population, then we have that subclinical. And if we had to look at that, that little square should be bigger than the others. This is kind of the place where we start, and nobody just wakes up one day and says, you know what, I think I'm just going to stop eating everything and work towards anorexia, or that bulimia thing seems pretty fun to do. I'm going to start doing that starting now. We start in a place of having our relationship with food and body get very disordered and unhealthy, and I'm going to talk about unhealthy in a different way going forward from this point, but I want to make the point of like it is disordered. So that can be an unhealthy relationship, but we're not going to talk about the use of health, being healthy or unhealthy in other ways concerning our food or body going forward. That's going to be one of the things I'm going to explain that could be a tip for help. And then over way on the right, we have a diagnosable eating disorder. That means somebody meets the criteria for having an actual diagnosable eating disorder, all of the markers, and it's causing significant distress and inability to function in their circumstances. So this population is probably going to be where we're going to have a lot of focus in the efforts of the things that are going to be talked about in this webinar. And it's still, most of those things can be used here. But we really want to tackle people if you are recognizing any of these signs in this place so it doesn't come to here. So let's talk about when it does get to that far right, here's what we're talking about. So I'm going to go over the big three that people usually are aware of and talk about two others that can have some other bearing or sort of weight, some things that you may see if you go in and get an evaluation. There are gaining in popularity in various ways. So the ones that people know of are anorexia, bulimia, and binge eating. So when we talk about anorexia, we are talking about the restriction of energy intake relative to somebody's nutritional needs, requirements for their body to do what they need to do, is significantly lower, and restricting that energy intake based on, again, this criteria. We're basing this on a significantly low body weight, meaning 85% or less of an ideal body weight that a person would need to be considered at that place that is a zone of normal, effective, just getting through your life day to day, energy putting and output, and everything is working normally, all your muscles, bones, organs, things like that. And it's also in the context of this does not create, this creates an issue for developmental trajectory, physical health, and other things. That restriction of energy intake and leading to a significantly low body weight is due to an intense fear of gaining weight or becoming fat, or even the thought of even though that they are underweight. So even if they are given the criteria, there's never enough that they are always pursuing a lower weight, because that fear is so intense and becomes more distorted over time. There's a disturbance in the way that somebody may feel their body weight or shape is experienced. So this has heavy influence. That intense fear often has a large influence on their own self-evaluation and what they feel about their weight or their shape. And there can be a very pronounced denial of the current seriousness of the effects of the medical or the developmental trajectory or physical health or even mental status, and sort of the undue influence and disturbance that the person perceives because of their low body weight. So this is kind of like at the most serious level of when we see an eating disorder, somebody's in a very, very dire situation at this point, because we are seeing that their relationship with food is very extremely distorted and severe on many fronts, that it is very hard to convince them to stop doing it because they are so intensely engaged in this distorted process. Unlike bulimia, which is another one that we hear a lot about, has the exchange of these two different things. So binging episodes and recurrent compensatory behaviors. Many people will start out in this place doing things like binging on a large amount of food in a discrete period of time, and we kind of cap that at a certain point. So a lot of people will use that word binging in a very colloquial or just common sense, like, oh, I ate too much, I think I binged all the cookies. But these binges look different. When it is an actual binging episode, we will see somebody not only eat a whole bag of cookies, they will eat chips, they will eat leftovers from last night, they will take time to eat all the other components of like bread, whatever they can, anything that's in their certain kind of like quick environment, and do it in under an hour, 15 minutes. I've had people binge a very large amount of food, just even food components, not even food, in a very short period of time, or have a set amount of time that they use to do that in until they actually feel that they can't do anymore. And that is also one of the things that happens with binging, besides a lack of control during the episode. They feel they can either that they cannot stop, or there is a lack of control in how one is consuming the food. So they're not stopping; they're just going and going and going. And one of the things that we look for too in the criteria is that they could actually end up vomiting or making themselves physically sick, and that is the only signal to stop. So that's something that we need to look out for as well. Afterwards, that episode can leave somebody feeling depressed, guilty, shameful, really numbed out, repentant, not knowing what else to do. So then here's what happens: we compensate for it. So on the other side, on the right side of the screen, you see some of the things that we may do. When we use the word purging, that is the technical term that we would use for self-induced vomiting, but purging can mean a lot of different things. So that's why we call it compensatory behavior. We're doing something to compensate for that binge eating episode. This can be everything from trying to self-induce vomit to overuse of exercise, abusive medications, whether they're prescriptions or over the counters or supplements, laxative abuse, diuretic abuse, fasting. There's many things people will try to get the food or get the calories or to make themselves feel better after that binging episode. And this is a repeated cycle that can happen multiple times a week and can be triggered by various things. We look at, unlike with anorexia, we will look for a certain frequency of actual episodes in bulimia and binge eating. For anorexia, we look at sort of where their body weight is in comparison to how much their ideal body weight should be, and the severity goes through that exchange. So when somebody is diagnosed with binge eating disorder, we usually will look for, again, those signs of binging that were on the left side of the last, but there is no compensatory behavior. There still is a really high amount of, in both binge eating and bulimia, influence on body appraisal or feeling good about yourself is directly related to what your weight or how you look. And that controls your self-esteem, how you feel about yourself. So again, these disorders can, be really mitigated about feelings about one's appearance, and then that could trigger engaging in these behaviors and engaging in the disorder to make yourself feel better about how you look. Yet it's never going to be enough or satisfied. So when we look at binge eating disorders, same thing, episodes. So we look at it as a frequency of how many binge eating episodes per month. And one only needs to have one episode a month to start meeting the criteria, along with the other things that meet criteria for a binge. So these are the typical three. When we look at things like the severity of the disorder, kind of like I've hinted at before, generally most of all of these have to have at least a minimum of 3 months in a time period of being done consecutively to meet criteria for the duration of these disorders. The frequency, again, is how often the episode occurs and is used for BN and BED. And like I said, the severity is based for anorexia right now on a BMI chart. But I know that's been something that's been brought up lately, and BMI is not a sole indicator. But when we get to really low BMIs for people, not really high BMIs, that's not an indicator of health or if somebody is in a good place with their body, and shouldn't be used in a disordered way. But once we get to a BMI of 17 or less, there are, no matter if you have an eating disorder or not, certain things that start happening to the body due to the effects of starvation and restriction of intake that we need to ensure are not at risk when somebody is engaging. So we use BMI for anorexia for a particular reason to indicate in the medical world that they are at risk for developing certain disorders or dysfunctions or organs shutting down due to their BMI becoming lower and lower and lower. Other disorders that you may see would be looking at things like OSFED, which is our other specified eating and feeding disorder category. We use this when criteria is not being met. So when we see somebody who might be subclinical and we're seeing that it's getting to that disordered, almost eating disorder place, or they're just meeting it, we may put them in this category to start that process of assessing how severe their behaviors are becoming, or that there is a concern that it could get worse. So that could be they don't meet the time limit for how many months or duration, they don't meet the amounts of criteria, but again, they're at risk for developing more and other things. You may also hear that there's other eating disorders in that category. One that has been getting a lot of talk, or a lot of sort of I guess, recognition in sort of media and news outlets, and also in many different ways of finding education about eating disorders, is avoidant restrictive food intake disorder. And there is also another one called rumination disorder and pica, which some of you may know. These disorders do not have a component of body image distortions or same cultural connections as the other three that I went over, or even if somebody lands in OSFED. So I'm typically leaving these out of this because we're looking at how to help somebody prevent or support them when they are starting to struggle with those subclinical or even have an eating disorder that is related to body image, and helping them resolve those things. But these are still valid eating disorders, and there is a lot of information that you can get on them. They are just as serious. They can have just as same as high risk as the others, and we should be paying attention to these more. And you should be hearing more and more about these as we go on and trying to educate in the eating disorder field what these are. So we know people have, just by definition, you know, there is the mind body connection. We know genes play a big role in mental health. We know all of these things. This is not excluding this category of disorders. So biologically, we know that if somebody does have a close relative with an eating disorder, there's a higher likelihood or risk that somebody will have an eating disorder in that same family. Now, this can be because of actual genetics, or because of learned behavior. There is, that nature versus nurture sort of thing that goes on in this. And one of the things that we look for is somebody else engaging in the house. We know that if there is even a sibling who has an eating disorder, of somebody who we suspect, that there is a higher likelihood that they will develop it too, because there's the genetic component, but they're also seeing that person possibly engage, or seeing all the things that are going on with that person's either treatment process or other things that are happening, and might feel influenced by it a bit. Having a close relative with a mental health condition, again, they are comorbid. So anybody who has major depression, anxiety disorders, OCD, things like that, it can also pose a higher risk, because again, we don't know if it's a chicken or the egg. And sometimes, because to cope with that mental health condition, people can end up developing an eating disorder as their means to cope. But then it just adds to the list. If there is a strong history of dieting prior to developing the eating disorder, so this means yo-yo dieting, fad dieting, all those things, getting hooked into various diets. If we find that a kid that is in a home where diets are regularly used, and a mainstay of what happens, and there is a very disordered or unhealthy way of looking at food, that these foods are healthy, these foods are unhealthy, these are good, these are bad, and difficulties with understanding kind of like how you go about nourishing your body, they are more likely to develop a disordered eating pattern, because they've grown up in a place that didn't know how to balance a relationship with food or their body. We also know that if somebody just has a negative energy balance due to athletic focus, and we're going to talk about that being a big component that is coming out now more so than I think was recognized before. You see that sort of word REDS. This is reduced energy deficits in sports, and this is our fancy term to kind of indicate that this person has an eating disorder, but they also are an athlete. And that a large part of their eating disorder and disordered patterns with food and body are recognized around their performance and need to, challenge kind of how they're changing their training and how they're performing, or else they will injure themselves more and possibly die from trying to compete. The other people who actually have a higher risk are insulin dependent diabetes, so type 1. There is a type of diabetes, sort of bulimia mix that we call diabulimia, where somebody, in compensating for a binge or covering a binge, will manipulate their insulin level in order to engage in the binge or to cover for it afterwards. This type of bulimia, the diabulimia, has the highest risk, I think, of all the different types of eating disorders, with a 40% mortality rate, just due to the toll that it can take on the body. This is just one of medical conditions that we know that ties into eating disorders. Others that we know of are mast cell disorder, as well as cystic fibrosis has a high rate of eating disorders just because of the toll and types that it takes on the body. Psychologically, we also know that there's some risk factors and other things that can put somebody at the place of possibly developing one more. It's not 100%, but these are things that we look for in conjunction with those biological factors. So if somebody has a penchant to be perfectionistic, or they have a temperament that has a lot of perfection in it from an early age, they have very rigid thinking, very black and white. It has to be this way, or it's no, or it's not. That person's going to have a hard time not having sort of structure, or being able to relate or be flexible to kind of have more understandings of how to balance things with your food or body. If there is a naturally a high image of, or a high rate of body image dissatisfaction that they experience, that is also going to be something that we look for amidst kind of the psychological risk factors that somebody can have that puts them in a higher place of possibly developing an eating disorder. If they've had a personal history of an anxiety disorder, part of that is because of the perfectionism, the rigid thinking, the intolerance to distress, and some of the things that go into an anxiety disorder are some of the same things that we see in eating disorders. They are fear-based disorders. They are also things that we see in OCD-related disorders, such as compensatory behaviors, same things that happen with compulsions. They are the same sort of cycles, just different ways of expressing some of the same circuitry in the brain or eliciting that, as well as some of the same things that can happen in an anxiety disorder can be soothed with an eating disorder. So we know that there's a high risk of developing something to get away from that anxiety, and this can be one of them. As well as behavioral inflexibility. If I have to do it this way and in this order, or other things, then we know that that person also probably is very rigid in their thinking, or needs to have a certain amount of control in what they do and how they do it. That can lead to, again, finding, having total restriction or control over food or how their body looks or their weight to be a very attractive thing that they can control, unlike other things that they will really try to control but fail. And this will be the area where they feel that they have the most control. Social risk factors that people can have. There is a thing that we call weight stigma or weight bias. When we, see somebody who has been on the receiving end of weight stigma, whether it is at home with peers, in school, in cyberspace, other things, we know that that is, or they buy into, some things about, kind of like weight stigma and believe those, that can be something that will lead somebody to an eating disorder. If they have experienced teasing or bullying, we know how much that can really affect people in different ways, but it can also affect and create, the effect of having an eating disorder to change your body or to control things that you can't control. The idea of having an appearance that has an idea, or an ideal appearance, and the internalization of, if I just look like this, then people will like me, I will be satisfied with myself, and I will be happier, becomes a very stronghold in many people who have an eating disorder case, that to the degree that this ideal is the only way that they can see themselves, or only see that they can be happy. So adoption of that appearance idea is really crucial to be sort of picking out if somebody is. The issues of acculturation or coming into this culture from another culture and trying to fit in is something that I have personally seen over the last decade and getting stronger, of something that kids will try to do, especially young kids, to try to fit in with their peers. If they see their peers are, giving into these ideas and, having these certain stigmas about weight, if they're getting bullied or teased and they want to seem like they fit in and they're not wanting to be marginalized, trying to acculturate to a culture that once maybe praised more kind of like a curvy figure or a different type of body versus this one, or that this is seen as not positive here, but this is, can be something that can create a risk factor. As well as not having a lot of friends and limited social networks that are real social networks, not and social media, but really having social connects in real life. They feel isolated and not socially accepted by peers. This could be something that could be a way to solve that problem, even though it is something that creates another problem for many kids and teenagers. So in term, when we talk about these, there are some differences between genders and sexual orientations. And so I am going to talk about this a little bit. These are the more traditional ways that we do see and know that people gravitate towards wanting to adopt this eating disorder sort of lifestyle or start adopting these ideas that lead to subclinical displays of eating behaviors that are unbalanced. So typically, and again, it's not across the board, but most females, if they are identifying as females, will focus more on physical appearance based on thinness or low weight to avoid weight stigma that they are too fat. We have called this over time the thin ideal, and it usually is from a common pursuit that is never satisfied. You can never be thin enough, you can never look pretty enough, you can never get skinny enough, you can never be a size small enough, your weight could never be low enough. It is the ideal that is never actualized. It is always going to be an ideal. For males, this is different. The physical focus is not necessarily on weight or achieving the thin ideal. The focus is more of what we're understanding is a physical appearance based on showing more lean muscle mass gains and structural symmetry, body composition, towards a more ideal male appearance or Adonis appearance. It's not always performance based. Somebody could have a lot of strength or a lot of endurance and not have that body composition. So this is more based in aesthetics and ensuring that that body composition stays in a certain place. So that is a very lean body mass with very low fat that can be dangerous for somebody to achieve and actually can put them in more harm's way. But again, this can become very distorted and distorted in certain environments that will be typically more promoting a lower weight or a certain aesthetic among various males, not necessarily based on performance. So that might be in gyms or in certain sports, which we'll talk about, that really have a aesthetic based component to performing that actual activity. When it comes to, again, people who identify on the spectrum of LGBTQIA+, often these are very highly susceptible populations and subcultures who are engaging in disordered behaviors just due to the body dysmorphia that these cause. Again, it changes your relationship with food, but also your body. And it can turn into trying to manipulate what your body looks like. And that can happen in kind of a variety of different continuous things, but it often is seeming to kind of be in either a pursuit towards on that continuum on one end is often to create a certain body ideal that they would like to be able to achieve. So if I want to be more feminine, I want to be smaller, I want to be thinner, I want to try to get to that thin ideal, can be something, or I want to be bigger, I want to have that body composition, I'm going to try to do that. Or it can be in other ways, try to prevent their current continued development into the gender that they want to avoid being. So for instance, if I am a girl and I don't feel that I want to be in that body, I don't identify as a female, I don't identify as a woman, and I notice I'm starting to have my period, I may start to restrict and sort of reduce what I'm eating, and try to stave that off in whatever way I can so that I don't have to deal with the changes in my body. I don't have to deal with a period because those things disturb me. They make me realize that, I am something that I really have a hard time accepting being. And I don't want to have that. So they may prevent from further development occurring by engaging in these behaviors because it can stunt growth. It can stunt even physical, just height growth, but also, again, any organ in the body gets affected by these. This has a big toll on physical health. So, contributing factors. We talked a little bit about the risk factors in all the areas, and some of those are contributing. So, one thing that I mentioned was bullying. We're going to talk about media effects and how that is not necessarily a new thing. We've known this for quite some time. And now we're just seeing social media ramp that up, as well as the effects of impact of athletics and physical competition on younger people. So when we think about this idea of bullying, um, it's really interesting to think that, this relates because of, again, that weight stigma that we might hold or what other people might hold, and then we start getting bullied by it. We have seen this being one of the bigger factors contributing to starting negative body image concerns, as well as low self esteem and depression in teens. And just doing that, it is a big contributor. 60% of those affected by eating disorders right now in the past couple of years when they polled, so in 2021, 2022, said that bullying contributed to it due to the weight shaming or the weight bias or stigma that people have, even on early kids that can carry with them until they're teenagers when they start doing these things. Or it can go on beyond into an adulthood and still have a big impact. And you might say to yourself, like, okay, well, that's 60%. And, Dr. Erin said in the beginning, like, we know more about, females being studied for years. And so maybe that's a large portion of this. But when we look at the actual stats, the prevalence of weight-based teasing is actually pretty same in boys and in girls. So we know that if somebody is teased very early on in their life, talking about 8 years old, again, that's kind of when they start to also think that they need to go on diets and sort of do these things too. So now we're starting to see the connections in this, right? So we need to start developing things early. It is very close. And this is a study in some statistics coming from NEDA, the National Eating Disorder Association. And the fact that, like, this isn't just happening to girls at a high rate, this is happening to boys at just a high rate, and how many of those have possibly gone off to the wayside on the male end of things. And girls, end up being more pronounced in eating disorders or studied more is a shame that that happened. However, they were being teased just the same and still are, and still have some of those weight-based biases or reasons to start changing their body or having a difficult relationship with it that can relate to depression and self-esteem issues and anxiety and all the things that lead somebody to disordered eating and possibly an eating disorder. So what are examples of body-based bullying or that weight stigma or other things that we might see? So peers could be making contacts directly in school or in social activities, obviously being labeled as the fat kid or the ugly kid in the class doesn't really feel really good, and it can actually weigh really, really hard on our, self-esteem. But also based in social media, comments can go around really quickly. We know the impact of social media and can be solely based on physical appearance with a lot of callous anonymity. Somebody could just anonymously tell you that you look horrible or your face is too big or you look fat or you look ugly in that. And you don't even need to know them. It could just be a row of different comments on there. And that can affect somebody, especially somebody very young who's not able to handle all the impact of that. And it can happen instantaneously. But I also want to point out that body-based bullying can also have an effect and be there in the home. So sibling bullying on appearance, as well as being given a nickname by a family member on physical appearance. This can even happen with parents, can have lasting effects on a kid. And sometimes we don't speak out about this. So if we have a relative who gave us a nickname about, our appearance, or we're getting teased by our parents and they think it's a term of endearment, There's many people I've treated over the years that are sitting in my office as an adult saying, I remember when my dad, would just call me like gordo in Spanish, that, is like little fat, chubby thing, or fat. And that affected me for my whole life, but I would dare never say, that that affected me to my dad. It was his term of endearment, and he sticks by that. Or my aunt used to always pull on my chubby cheeks and say I was so chubby, and she loved my chubby cheeks, and it got to me every single time. And this is adults in my office that still remember that very clearly from childhood. I also want to point out from authority figures, so not just in the home, but we also need to consider coaches, teachers, activity facilitators that are making comments about bodies or not giving opportunities to teens that are in heavier bodies or bigger bodies, that can have effects on how they feel their self-worth or body appraisal is. That they get sent to different sections of physical activity class, or they're not making teams because they weigh too much, or coaches are not putting in players because of they seem like they would be not really good endurance wise in doing this sport, and sort of steer them away, even though they're really interested in doing that. And then also promoting too, that happens throughout the entire school. I've talked in many schools where things happen in various ways. From in fitness class, we use MyFitnessPal, or we talk about, not eating things out of a box or a bag because it's bad for you and it's unhealthy. And for this little portion of the population that ends up creating eating disorders for themselves to structure their world, that's like kindling that sets off a bonfire. So we need to be more attentive and be aware of, we can't bubble wrap the world for everybody. However, we can be aware of how we possibly present things and what we do, so that we don't end up creating something that can turn into something deadly later on. So when we talk about media effects, I always like to bring up these studies. Um, there's lately been a lot of talk about social media, and people even suing things like Instagram and Facebook for, again, influencing and knowing that they have a really large influence on younger girls, on how bodies are, kind of put out there in thinspo, and sort of distorting of body image and making them have depression and low self-esteem. But we also know from the early 90s that younger women, and probably younger boys, again, this is one of those biases, we did not really look at the boys in this study, but that this has been actually happening for quite some time, and we know the effects of media outreach on kids. So in the 1990s, mid 1990s, like about 95, Fiji, Papua New Guinea, was the last place on Earth that didn't have access to westernized cable. They finally got access in 1995. And some social anthropologists and anthropologists thought that this was like a really good place, or a great set of factors to actually study this and see what happens. So this was the last country that had no contact with Western cultural norms. And so they received access, and the only controlling variable was access to cable TV in 1995. So we're talking like 90210 and Melrose Place and all those things that you remember if you're old like me, and remember those shows. So there was a lot of access, Baywatch, all those things, right? And a curious thing happened. When they started, they found that in 1995, after 6 months, or at the start, 3% engaged in compensatory behaviors. 13% after about 3 months of watching this to 6 months scored high on an eating disorder criteria test. They went back 3 years later and tested again, and found out that now 15% reported compensatory behavior, so binging, purging, trying to lose weight, all those things. And 29%, it doubled basically, or tripled in some cases, scored high on eating disorder risk factors or actually met criteria. When they polled girls, and they started doing this with 13-year-olds to 19-year-olds, the girls said that they watched television 3 or more nights a week in the late 1998 survey, that they went back again. And 50% in that survey said they were more likely to describe themselves as too big or too fat. And 30% were more likely to diet than girls who watch television less frequently. And that was just being exposed to it in 3 years on a couple nights a week of TV. So we know that this has an impact. We know that social media is more instant, it's faster, it has a much wider reach, and it is much more influential. And if we knew this back then, we could have taken this and done a lot more with it. But I think a lot of people weren't aware that these things were occurring and that this was something that was definitely an impact. And this was before social media even existed. So let's talk about this. Just because there's social media and that we can't stop it, we can do a lot of things to prevent it. Social media can be detrimental. We know that there's a lot of documentation of the effects and research on the influences around body image and ideals that it populates. Even social media companies have found in their own internal research, yet kept using their own products, produce this effect in preteen females and probably males if they looked at it harder. Social media use can be detrimental to most preteens and tends to be due to the fact of documented areas of effects around the body is about influence around body image ideas that it populates. And it can do this very, very quickly. I've done this experiment too with also my patients is I will just create a fake Insta account and I will just start looking up various hashtags, which I'll show you in a second. And then I'll have them come back in a week and they will see that that whole Instagram is just flooded and I can't even stop it or change it. It will just be nothing but how to change your body image, very negative things, eating disorder stuff within a manner of like 24 to 48 hours, but within a week, it's a juggernaut. And it will continue to populate that. And one of the things that, sadly enough, we don't have privilege to is that logarithm, and it changes all the time for all these social media outlets. So this isn't saying that, again, you need to tell your kids to avoid all social media. The more that we forbid something, the more it becomes forbidden fruit and we're going to go to it. And even if you forbid them having a phone or having those apps on your phone, most likely they're looking at it on somebody else at school's phone or in some other places that they can get access to social media. So rather than fight it, we need to be smart about it. We know that even though social, media companies, like I said before, have found their internal research and people are suing in litigation about this, that their products produce very negative effects in preteens, especially females. So what am I talking about? Those things, those hashtags and other things. So common examples what we know with eating disorders that have been for the time and for space, even just on the internet before social media, are looking up these things like thinspo, inspiration, Anna, Mina. Anna is for anorexia, Mia is for bulimia. So pro Anna, pro Mia is pro anorexia, pro Mia sites, weight loss, fitspiration. Most of the time when you come up and you start looking up those things now, you're going to get a flag on any sort of social media or website that says, please seek out help for an eating disorder because it's become very, very much proliferated. But recently people have gotten sneaky and they will continue to. So for instance, if you look at the recent examples on the right, Ed Sheeran, why would that be anything about eating disorders? Well, if you take those first two letters, it's ED. So there was a time where Ed Sheeran, about a couple years ago, was trending everywhere. And we didn't really understand why, because it didn't match with like the content that was on there. And it was because it was a way to signal ED and to show your thin pictures and to compare bodies and to do these things and to get inspiration for your eating disorder. So Ed Sheeran became famous just a little bit more intensely for a little bit. A4 challenge is taking a piece of A4 paper or 8 by 11 sheet of paper and seeing if your waist fits perfectly within without showing on any side. So people were on social media showing that their waist fit within that A4. So about 8-inch waist on that. That was something that was going on for a while and still pops up every once in a while. If you see anything again with ED, Ed Talk was a big thing. What I eat in a day is still going strong. I would say this is something where it doesn't matter what you see anybody else eat in a day. They're a different person. They have different needs for their calorie intake and other things. You don't need to know what they eat in a day. And what they eat in a day may not be what you need to eat in a day. And you can't even tell or prove that they ate that, what I eat in the day. So let's think about kind of what they're showing us versus what is actually the message that's being sent versus what we're buying into. Brandy Melville is a clothing company that got into a high rate of issues a couple of years back, especially in 2020. They're still very strong in Asian countries, but they are a clothing store, a physical clothing store that only sells size 0. So if you were a Brandy Melville girl, you knew what size you were, and that is the only size clothes that they fit or sell. And if you see things, you can see things like collarbones. Obviously, probably that word would be flagged, but if I change one of the O's to a zero, that may stick around for a bit. So what I would say is we're going to talk about how to kind of support and help, but think about kind of some of the social media influences and how um, more pointedly sort of keen it has gotten and more secretive and more um, thought through in sort of how it deceives or how it sort of creates this space that may not be known about. And that will forever keep changing. So we need to be smart and educating people and showing them what is appropriate social media use, or if you see any of these things, especially Thinspo or Thinspiration or Fitspiration, or if you find anything that is tagged on your phone as a parent or a consumer, start thinking about why that's being built and why you're gravitating for that. Um, I always ask people to be a healthy and savvy social media consumer because it's very, very much needed. I want to briefly talk about eating disorder in athletes. We can have a whole other discussion about this in a whole many other ways. But eating disorders in athletes are starting to be an area where we are really looking at because we are seeing that there is a lot of internal pressure to do higher in performance, endure more, be stronger, last longer, get, kind of shorter times, do that, in such a way so that your performance is peak. And some of the things in this area that have come out recently, especially with Reds, that reduced energy deficit in sports is very scary in terms of what this does. It seems to be the exact opposite of what an athlete wants to become and can prevent them from actually pursuing their sport or being able to compete professionally if that's their dream. This is also something that's not fully noticeable by people around them or even the person, because I'm an athlete. Why would I have an eating disorder? I eat. But there's a lot of things that we're going to go through in just a sec that I want you to think about in terms of like how you can be smarter about how maybe you pick a coach or what sports you go into and sort of why those are sports that you go into and how to we never want to take a sport away from somebody if they're coming in with an eating disorder. There's actually programs that are designed to help somebody balance that out and get back to a healthy place with their sport and movement. And movement is something that should be done in a joyful way. But in these cases, it's not. And we really need to make sure that there is a way to help these people. And in fact, it's becoming more and more pronounced even outside of this country to the fact that there is a large amount of athletes in the UK that has been a big source of really recognizing Reds right now because it's happening at a larger level that even their health system can't contain. So the sports that usually kind of place emphasis on weight or aesthetics, or where we see this happen a lot, are things like wrestling, because we need to make a certain weight. Lifting and powerlifting and weightlifting, bodybuilding, or in other places where like you need to make a certain weight or get into a certain category. Gymnastics is another area where kids can start off very, very young and be called the flying squirrel or the little person who does the parallel bars. And if they don't get to be that anymore, then they don't feel special. I've had more than one little kid come in and be very upset that they're either told that they're too big or too tall or they're not able to do that anymore. So they will be pressed to be the little tiny one that can do that and feel a lot of pressure to maintain that because that's what they want to do and that's what their coach wants them to do. Cross country and field, again, more of the running and endurance. The thinner you are, the quicker you're going to be for a lot of coaches, where I've had many more than one conversation where this is not a healthy thing. People are passing out on the field and having cardiac arrest and other stuff that it's dangerous. Track and field in certain events too, as well as ballet. There is a high amount in that category, particularly of dance, just because of the aesthetics that's needed to have that thin form. And most kids who say they start off in ballet and take it more seriously over time are aware of a lot of the body shaming and things that happen in those courses and classes, and especially a lot of the older teachers will put a high emphasis on keeping your weight a certain way, and it has nothing to do with the actual dance. And this is something that's embedded in the culture. And so part of this, we need to look at kind of the teams that we're placing our kids on, the coaches and the training programs or camps that we're sending them to, especially if they emphasize extreme competition. Most coaches and trainers provide obviously sometimes very dangerous messages, but sometimes misinformed messages about fueling the body and hydration, rest, and training in general. And there is actual evidence to support this, that 1/3 of coaches and trainers, when they looked at this huge population, thousands of them surveyed, had nutritional awareness or education in some form. 1/3. Less than half of that third actually had used information that was empirically supported or evidence-based. What I can tell you is I've had coaches tell kids that they need to go on the keto diet or paleo or eat no carbs, go gluten free because that makes you faster. I've had multiple kids from the same team come into treatment at the same time in the same program. Why? Because the coach said something and they all started doing it because one kid started to get faster, then the rest of them had to start doing it. And then they all found themselves in this place where they couldn't perform. They had stress fractures. They were unable to, walk, had drop foot, all these things. So there is something that we need to kind of think about, and there are resources that you can get and things to be kind of a questioning and very supportive parent or support system in team sports. If you even go on to NITA, and they have a bunch of things called toolkits. There is one for coaches and trainers to get a little bit more aware of what is considered an eating disorder and how to start helping somebody or prevent people from engaging in these behaviors. So again, most coaches do not have the nutritional acumen and training acumen that they really would need to make sure that things are safe. So be aware, ask the questions, do your kids some, due diligence. Be in that category of making sure that they're doing their sports safe and learning how to do it safe. So when we go into kind of things that are observable signs of eating disorder, disordered eating, we're going to look at things behaviorally, socially, otherwise. So if we start to notice in some way any sort of clothing changes, they're wearing clothes that are like 3 times too big, and it's not really because of fashion, they're just constantly wearing that, or they're wearing clothes that are really tight or really loose, or clothes that are covering up most of their body and it's like 90 degrees outside and it doesn't seem kind of in the usual way that we really would see it, we're probably going to need to look at that a little bit. If there's a change in bathroom use, either the frequency or duration of what's going on, and we don't have any other explanations, or if that bathroom use happens right after eating, we may want to look at that a bit in the home or even at school or other places where we may interact with people. That bathroom use change, if it seems out of the norm and just all of a sudden goes up in frequency or longer duration, is something that we have to consider. If a person is constantly fidgeting or restless or constantly checking themselves, so they may like, kind of do this or like, oh, yeah, okay. Or like check their stomach or their thighs. Usually they're checking to see how much fat is there. They're worried about their body image. If you see them kind of pinching or constantly rubbing or looking in a mirror or things like that, and they can't stop, that's something that we need to kind of pay attention to. When we look at their relationship with food, some behavioral changes that we can see is drinking habits change. Either they decrease what they're drinking or omit certain things, or increase the presence of other things. They're only drinking water and a lot more of it, like to a high degree that they've never done before, or only drinking caffeinated drinks, and they're doing it in a very high way, or they're drinking very, very little of anything. If they're avoiding certain foods that they once ate, whether it is food from home, or also at school, if they're skipping meals, if you're giving them a lunch and they're not eating it, there's probably signs that you can see. They could probably throw it out, or if you're missing like Tupperware or other things, or if they never take a lunch, they say that they're not hungry. They could actually sit at a table and avoid eating, and say that they're not hungry or want to go do something else. That can happen. Sudden food preference changes. So again, it's not to say that vegetarianism, veganism, or other things are not allowed. We do treat people who are vegetarian and vegan. It is possible. But a sudden food preference change, like they became vegetarian immediately in the last month and they're sticking with it for life because it's an ethical thing, or they are now a very strict vegetarian, whereas 2 weeks ago they weren't, and they will not eat anything unless it is vegan. That is something that is what we would look at. If somebody is culturally coming from a place of a culture that really embraces and sees vegetarianism as a part of their cultural heritage and understanding, we're not going to change that for them. And even veganism. Veganism can be a part of actually many cultures, from Indian cultures to Jewish cultures, part of, again, a large part of what, again, the Jewish kosher diet is pretty much vegan items that can be fit with meat or dairy items just to make sure that we're keeping kosher. So they eat a large part vegan. So we need to respect that. We can't really tell anybody that they need to eat a certain way. I think we're being open and understanding in how we do that. But if it is more of an extreme diet, they want to be keto for a very long time and they've been doing it and it's harming themselves to the degree where it's having an impact on their liver and kidneys or other things, we're going to stress that they need to stop doing that. Or if they're intermittent fasting and the fast goes for 24 hours a day, we're going to look at that. That makes no sense for anybody to be doing that. If we also see somebody starting to steal or hoard food in strange places, like under their bed, in their room, in their backpack, this could be due to food insecurity, but it could also be because they're feeling shameful of having that food around and they're stealing or hoarding for certain reasons because they're probably going to binge or they want to keep it close or it's a way to kind of keep them from actually acting on it. If they could just smell the food, if they can just see it or feel it, then they may not eat it. They could test themselves with it. Also, excessive uses of things like mouthwash, mints, or gums can stave off appetite or, get rid of like the smell of possibly purging or other things that people would do. Socially and emotionally, if you start to see somebody having a fear of eating out in public with others or just eating with others, that's something that we need to keep aware of. Extreme mood swings, that can come with a lot of things, but if it's paired with all these others, we kind of need to look at that. Extreme sensitivity to body changes. If we notice that somebody is really being very, very sensitive to any effects of what changes, even the most minute thing on their body, and they have a very extreme mood swing of it, or they're sensitive to that changing, or to clothes not fitting a certain way, or feeling too tight, or that they have a new blemish on their face and they break down, those are other things that we need to look at, like what is so important about this appearance, kind of factor that might be part of possibly disordered eating, or a component of it of, negative body image. Upset when people make comments about their body or appearance or constant comparison to other kids or other people. Again, this can be a facet of like bullying or other things. It also could be a facet of using a lot of social media use. But typically what is seen is upset about comments about their body that, hey, you look good. What do you mean? What do you mean I look good? Do I look fat? It's kind of what they're hearing. Or, you look healthy. Do you think I got fat in my face? I look healthy? That doesn't mean the same to them. So when they get any comment, even if it is a comment that you feel is a good one, there is something in there. If they're having those really strong reactions to it, we kind of need to make a point of, yeah, there's something going on. That if you're having that much upset to me saying that you look healthy or that you look good or you look like you're, gaining weight in some places or you look like you're filling out, when you didn't before, there's things that can be extreme signs of upset with those comments that we look for. Really observable signs that I want to say very quickly. If we see any of these things, so physical or cognitive, so something like they faint, there's blisters or calluses on their fingertips, particularly on these two, on either of these fingers. So the blisters or calluses on the knuckles are something that's called Ritter sign. If somebody is using their fingers to self-induce vomit, you will see that over time develop. Changes in somebody's complexion, often blue, they look like they're cold, but also things, somebody saying they're often fatigued, exhausted, poor recall about events, perseveration, particularly about food and body. These are all really late stage kind of signs on physical and cognitive that we need to pay a really good attention because now they're probably in a place of being possibly diagnosed with an eating disorder. So when do you seek out professional help? I would say any physical symptom that is frequent and severe enough, go. Go to the doctor, go to the pediatrician, express your concerns, or go to an eating treatment center and get an evaluation. Any assessment or evaluation is free. Go. If you feel like your pediatrician isn't listening to you or isn't seeing it, then get a second opinion. If you are seeing something's wrong and it's been happening very frequent and severely in a short period of time, go seek out help. Severe engagement does not necessarily get noticed at first. And so in terms of like if they're engaging in things like purging or laxative abuse or other things, and we know that that's happening, it may not be observable on the outside. So we need to go to a source to check out the inside and what's going on. There's been many people who have come into program at a lower level of care, and we do those tests and different things, and we find out, oh my God, if you don't get to the ER right now, you need a lot of electrolytes or your heart's going to stop. That's serious. And you can't tell that on the outside. They're like, I feel fine. I probably would too. I couldn't tell the effects of how much electrolyte I have in my system or if it's down or if it's low until it's at the way end. If we also notice that there's a rapid decline in observable health status, like you've known this person, you've seen them go through things, and then there is just a total dip in sort of what happens, or if there is an academic decline, again, those cognitive things, poor recall, I can't focus. I'm so obsessed and focused in other areas that like I'm letting my grades go when I usually get straight A's or do really well. Or if they start having noticeable social difficulties, the isolation, the feeling like they can't connect to people or really sensitive to comments, we are going to get them help. If we see a cluster of all these things, we need to seek out help. And if they do say, hey, I've been engaging in this or I feel like I need help, get them to help. Don't dismiss it. Get them to help. I would say any preteen or teen that has, again, a good enough relationship with a support system that can say, like, hey, I've been doing this. I know it's not a good thing, but I think I need help. Take them, get them help. Don't berate them. Don't dismiss it. Take them to help, and get them to help as soon as you can, is the biggest thing that I would encourage anybody to do. So I don't know why that is highlighted that way, but excuse that. So when we look at what professional help looks like, we usually take an eating disorder as a treatment team-based approach, which is the combination of several professions who can treat an eating disorder, including a psychotherapist, a registered dietitian that is eating disorder specialized. Not every dietitian is, and it's a dietitian, not a nutritionist. A registered dietitian. A nutritionist has no schooling or education or a degree or a license. A registered dietitian is what you need to seek out. A primary care physician and a psychiatrist. We all work together in a combination because we have to treat all the different facets of the eating disorder. Common modalities of when somebody does get treatment, we use CBT-based treatments are pretty common and evidence-based. There's also a family-based treatment, which we commonly refer to as the Maudsley method, that is very, very successful, especially in younger kids and in younger preteens. It includes the family very largely in that work, and can be very, very successful in getting that family to bond together over food instead of having them break over food. The motion focused therapies are very popular and have some good evidence behind them. Internal family systems work or parts work is used for a good portion of people that, especially on the binge eating disorder end, that really works well. And inference-based CBT, which was first developed for OCD and anxiety, has also protocols for body dysmorphic disorder and eating disorders. So, and that is something new that is coming out and really very much a good area of new clinical evidence-based work that is just another modality that can be a source of help for people who are really struggling and need professional help. So that's what the professionals can do, but I don't like leaving this without what can I do today? There are things you can do today. There's things you can do to start. There is hope. There's stuff that you can do even just after this webinar. You can start. And that's the great thing about this. There is tangible ways that you can start doing and reversing and preventing and supporting today. The concept I want you to consider in all of this is when you start changing these things, whether they're in the home or how you kind of support or how you present, certain things, is that we're going to be considering moderation, balance, and variety. And we need all those things to be in harmony. So everything needs to be in moderation. Again, if you eat too many pieces of broccoli and you just eat broccoli, that's probably not going to be good for you. But if you eat too many brownies, that's also not going to be good for you either. It needs to be in balance, but also not all broccoli. We probably should put something else and have some variety there, right? Same with exercise, same with other things. We need to do it in moderation to what our body can handle, but we need to have a balance of different, things that we're doing and keep it in a stride, not too much, not too little, but also a variety of things that bring us joy. So these three words, when we kind of keep these three things in consideration, we have an optimal way of helping. So how do we do this? So, in order to create this in the home, we're going to create different things with how we communicate and what we do and what we allow and sort of how we interact with people who might be struggling with disordered eating or an eating disorder. I really ask everybody to be aware of food and body language. The terms that you can use, even when you're talking about your own body or food, can be influential in so many ways that you are not aware of. So, how you talk about food, food is neither good or bad, right or wrong, healthy, unhealthy, it's food. It's your moral determination about those food that makes it good or bad, unhealthy or healthy, or the messages that you are sent that makes it different. If you constantly talk about your body in a negative way, this is one of the factors that we know that highly contributes to kids starting to see that, hey, at 6 years old, maybe I need to change the way I look because mom always looks at herself in the mirror, my sister does. And they always make critical comments, or I'm going on my diet, or I need to lose weight. And it may not be intended to be heard that way, but it is heard. So the way that I say is, again, just be aware of your own relationship with food and body and the language you use. Be aware of not using it, especially around your kids or somebody who's really struggling with it. And if you hear this language coming out of them, then we need to start being aware and start listening and supporting in a different way. And when I say listen, it means listening to what your teen or your kid is saying, not saying something over it, just listening. Active listening is the greatest thing that you can do. It is the simplest thing. It's just listening. It doesn't have to be right. It doesn't have to be wrong. It's just listening and asking for clarification. Did I get that right? That you feel sad and that you don't like your body right now? Is that what what I'm saying or what you're hearing? Or that you feel like people are judging you for your body? Is that what I'm hearing? And get their version of it. Most of the time, this can be more powerful than anything else. I usually ask families, like, don't praise on physical appearance or looks ever. There's no need to. We don't need to kind of have, a running total of like, you look good in that, or you look skinnier, or just that looks good on you. Um, we could start inadvertently creating an issue by doing that. So we're not going to comment on bodies, how they look thinner or bigger or more muscular or other things, especially when you know somebody's struggling in the home. We're not going to do that. And we're not going to punish for engaging in things like if we discover that they're starting to fad diet, their social media use is unhealthy, we're going to be curious and open and supportive. The thing that shuts kids down from talking about it anymore, or not even saying anything and becoming more secret, is when something is caught, because these are secretive disorders, and a parent or support punishes them for doing it. Why are you doing that? You know that's not right. Don't do that. Stop using that. Stop dieting. Da da da. They're shutting down the conversation instead of helping. Instead of saying like, can we talk about why? And I want to hear from kind of you what was going on. I just want to listen. It seems like you came across these things, and I'm curious and I want to help you. Not punishing them for doing it is the biggest thing that I would really ask you to kind of consider. Be open to it. Changes you can do today. If you're at home and you got a scale, ditch it. There's no reason to be taking our weight. There's only 3 situations where we need to take a weight for anybody in any medical situation. That is, if you're a pregnant female, if you actually have an eating disorder, we need to weigh you to see progress. Or if there's a chronic condition like cancer or other things that has an impact on your weight, we might need to do that too for, certain similar purposes. Um, or if you're a growing kid, but the kid doesn't need to see the weight. You can do them blindly. And these are the only situations that you need. Other than that, you don't need it. The weight on that scale is trivial compared to everything else. We want to adopt what is called the health at every size mentality, that you can be in a bigger body. And if your labs from your blood work, your overall health is considered in balance, your chronic conditions, if you have any, are considered controlled, or you have no chronic conditions, and you are maintaining your health in a very much moderated, balanced, and varied way, it doesn't matter the size that your corporeal vessel is. We just want people to be healthy at every size. It does not matter what your weight is. So it doesn't mean that people at 120 pounds, if they're female in this weight, that's optimal health for that person. That person may not be healthy. So I want you to consider other factors. And there is a place called the Association for Size Diversity of Health. Even if you look up HAES or Health at Every Size, you will go to them and they have principles and you can take these to any medical provider or start using them, but ditch that scale. Request that weight is not discussed unless necessary in a medical office for your kids, that you can take a blind weight. You don't need to know your weight. You can also ask that the provider does not discuss the weight with your kids, but can discuss it with you. That is always an option. And if they do not want to abide by those rules and they don't seem to accept the health at every size, you can change providers. This is the one area in eating disorder world where we are really making a big push. Medical providers are one of the areas that can create the most medical stigma or weight stigma, but they also have a really big influence in not doing that. So even at the Health at Every Size website, they do have a list of HAES affirming providers that you can go to, or you can download the information and get them to be aware of it so that you can make that informed choice. But you can always request these things yourself. And if they say no, it's probably not the medical provider you want to be with. We want to promote an all foods fit and food is fuel mentality in the home. That means broccoli has much of a place as brownies. If we start taking or omitting things, then they're forbidden, right? So we need to have a relationship with both so that we don't overindulge or feel guilty or see it as bad or good and place it on our self-worth. All foods fit. Everything is good. Donuts are amazing. Carrots are amazing. Everything's great. And we want to promote joyful movement, not movement to a detriment because I need to lose weight or I need to get healthier. It's like, hey, I actually enjoy doing this movement. I'm finding this moment to be joyful. So movement can be anything, but we don't want movement to a detriment. We want joyful movement, something that can help you be embodied instead of take you away from it. Again, being that savvy media consumer and model this with your team. So even if your media, social media today, go look at it, see how much you're seeing that stuff and what you're looking at. Start changing it, start blocking those sites, start doing those things, report people. I tell everybody who I treat, if you see a post or a thing on any social media that's promoting kind of like bad, unhealthy habits or really unhealthy messages, report them. Report them. Take back your action, but also know what they're trying to convince you of and sell you. And we can model this for our teen or our kids and how they sort of interact with social media as well. We're going to hold on that rule of no commenting on bodies in the home for all people. That, again, there's no reason why we would need to comment on our bodies, that everybody is very well aware. And if there's going to be comments on our body, we're going to comment on its function and what it did for us and what we're grateful for that day instead of its physical appearance. That can be the way that we start. And we're also going to have a plan for how to cope when others who may engage in unhealthy commenting and practice and what to say. So meaning if we have other family members or other people in our support system that aren't on that same train, that we can have a way of how to cope with it. We can partner with our family members. We can tell them, hey, we need to change how we're talking about this, that we're not going to grab cheeks and chuggy and all those things or call, by their nickname, even though you think they're cute, or comment on bodies. And even if we can't control other people, we can control how we cope with it. So we may limit our time or have some things that we may need to do with the family members who are supportive, eating with them or doing other stuff or staying away or avoiding conversations that we may need to engage in or practice to get through those situations with people who are not going to be so open to doing that. Other things that you can do today, the family that eats together, stays together. This is so important in so many different facets, and eating disorders are not the exception. Make efforts to eat meals together, even if it is like breakfast in the morning, a couple of snacks, a couple nights a week. Make efforts to eat meals together. You will have a better understanding and more support and more ability to communicate, which can open the doors and give support in so many different varieties of ways that this can actually help more than you know, and not just with eating disorders. Focus on promoting self-compassion, not only for yourself, but the praise of the process of accomplishment, not the outcome. So what I mean by this is when we are promoting self-compassion, we want to focus on, hey, you did all of that and you worked on that, and the process you did was so important. So you spent all that time studying, and it's not based on the outcome. that, okay, so you got the B and you wanted the A, but look at how much you put into that. That is great. So you didn't win the game today, but you had so much fun playing with your team again this week and you really practiced. I'm so proud of you for that. Or I saw how much work you put in, can give a kid better understanding, or a teenager or anybody, not to focus on the outcomes for validation. So not how things appear at the end, but being more confident and being able to pursue things in a different way that can combat things like being bullied, going towards things to feel better, to change their body, or developing other things like mental health conditions. So we want to praise the process, not the outcome. And a lot of people praise the outcome. They only praise Sally or Johnny for when they win the game, not ever for when they don't win the game, or whatever they put in that game that they didn't win. And that is very, very, very much an important thing to consider, that we need to focus on the process of accomplishment. I would say continue to have running discussions about social media, television, and films, body image influences, negative messaging. This is not a one-time conversation that you should have with your loved one or anybody who is struggling with this. We need to have a running conversation. This is not a one and gone, we're done. This is a running, continuing conversation. Even if we're trying to prevent, we're still having this conversation. It is only going to make your kid or your loved one healthier and being able to become a healthy, well-adjusted, well-meaning adult who can independently function. They're also going to learn how to emotionally control and regulate in these areas where it can be unduly influential and create a lot of other things going on in their life, and a lot of other stresses that can lead to mental health disorders and eating disorders. So again, making sure that your medical providers are HAES affirming providers. Go to the Association for Size, Diversity, and Health. Advocate for your kids' well-being at school. Stop the use of calorie trackers in classes or PE or practice that promotes arbitrary weight bias in any way. Just stop. It doesn't make sense. um, you can have a voice. And if there's enough voices like yours telling the school, telling, the various classes or activities that this is not something that you would put up with or you don't want them to have, that can be a collective voice. And that can be something that can change how your kids enter into their environments that they're constantly in and how they're influenced. So, things that I want you to take away from this are: eating disorders are real and they're very impactful. It can affect anybody. Nobody's immune from this, but we know certain people have certain risk factors or increased, possibility of having one, but nobody is really immune. Preteens and teens, both male and female, are highly susceptible to developing them. And they develop challenging relationships with food in their bodies, but we can see the signs earlier than this, even when they're kids. And we can prevent that. We can do things starting today. Help and support are available, and they're free resources available for teens and families and even adults. I have a handout that you will get after this of free resources, from nutritional to body support, body compassionate services, to even a place that makes a little card that says you can hand to your medical provider: do not tell me my weight, or do not discuss my kid's weight with my kid. And they're all free. There is a lot of different stuff in the eating disorder world that has been built over many years, because these were, um, you know, uh, definitely deadly, and many people did not take them seriously for years. So the eating disorder professional community has come together like anybody, like no one else that I've seen in any other place, to offer so many free resources to get to help and services and get that message out, because we had to battle for so long, even being recognized as a mental health disorder, that needed serious behavioral change along with physical monitoring. And thankfully enough, we've gotten there. But in that journey, we still maintain resources for everybody that need help, because nobody's immune. And when we can change all these things for a better, we're a part of a different way to engage with our own food and our bodies, and we can positively influence other people around us with that same change. And that's stuff that you guys can do today. That's stuff that you guys can tell somebody else to start doing today. That's stuff that you can model today for people. And I think that that's the greatest thing that we can do, is just to be aware, educated, change what we're doing, help support somebody change what they're doing, and not shame people for doing these things, and not fueling these influences that are so negative in our lives that creates these dissonance with body and food. So again, these are the two handouts. The levels of validation are ways that you can start actively listening and adding on to that. You can definitely go into that more. You'll see more on the International Association of Eating Disorder Professionals. That is the association that I'm a part of that certifies practitioners. If you wanted to know more, you could always contact me later about that. Or if you're looking to get certified or focus on eating disorders too, I can answer those questions outside of this. National Alliance for Eating Disorders too is another great place. NEDA, all of these will be on that eating disorder educational and treatment resources handout. So I wanted to thank you. If we had any questions or anything, now's the time that we can. I will stop sharing so that we can go back to answering these questions and doing all these. I know we already have one in there, so and that came on pretty early. Okay, so what about a diagnosis of GERD or gastroparesis? So what I would say is this is secondary potentially to an eating disorder. It could be something that, again, gastroparesis is something that can occur when we do have an eating disorder. That means, again, our stomach isn't functioning the way that it should. We can create the issue of GERD or gastroparesis just by engaging in an eating disorder long enough in any of those eating disorders, because we are changing the motility and way that our digestive system works by either not feeding it, overfeeding it, doing it in a weird schedule. That could be many ways that, again, the physical body is affected by these things to the point where people need really serious interventions about those. That can be very scary. So yes, hopefully that answered the question.
While we wait for more questions, I just wanted to say thank you very much for all of that awesome content.
Oh
Not
yeah,
only is it invaluable, I feel like the way you deliver it is really wonderful to listen to. So thank you.
yeah. Thank you. I'm very passionate about helping these people and helping eating disorders. Um, I'd rather not see people die from something that I can prevent and really help them in many different ways. So I can talk to the moon and back about this and probably will continue for the rest of my years that I'm doing this. Any suggestions to open up the lines of communication when a child becomes defensive or refuses to engage in yes. Oh, this is a good one. I love this. Okay. So anonymous, I get it. This happens a lot. So it might be, again, how we might start and open up those lines of communication could be the thing. So those levels of validation, the active listening. If the child becomes defensive or refuses, there might be other reasons why that's happening. If we've started to change how we're communicating and then all of a sudden expect somebody to open up the lines and be totally forthcoming with all the things that they can been keeping secret is sort of unrealistic. But if we over time allow that space, in some sort of situations, I would say even if a child, if they're refusing or getting defensive, and we know that they're really showing a lot of those signs that we need to get them to place, like let them refuse and get defensive. We're going to take them somewhere and get an assessment. Like they can be as ornery as you can. And sometimes I would say that child might be actually so active in their eating stuff that you're not even talking to your kid anymore. There's many people that have treated that it's like, that's not that person. The eating disorder is taken over and you're talking to a very starved or obsessed or perseverative, very distorted person who is so invested in destroying themselves that it just breaks down any communication. They're not willing to see it. So what I would suggest is we can do as much as we can to keep it neutral, not react, keep those lines open, let them speak, not speak over. So listen and validate that, yeah, I know this is a hard conversation. It's hard for me too. I'm curious, I'm here for you, I'm concerned. And just kind of leave that open, but also be assertive about if it is really like difficult, like I have not seen you eat in like 2 days and I'm very concerned. And you actually look like you were passing out last night when you were walking in the door. And we just got a call from somebody that you actually did pass out in gym class. This is stuff we can't ignore. And if they're going to be defensive about that, let them be defensive. And at that point, that's kind of at a very severe point. But I think it's also how you deliver it. So the thing besides active listening, I would say parroting. So even if we just say back what they just said, like you're very frustrated at school, Okay, I hear that. Is something that we can easily start doing that can make somebody feel heard. Using the end of the sentence that they just expressed. Yeah, I can see why you don't feel like you're listened to a lot. Please, I'm here. I want to listen. Can be sort of the bridge. Not using you language, using I language is very important too. So every statement that you come out with about sort of how you feel, how you think, how what you're about, we don't want to start it with like you're always not eating, like you're getting really defensive about this, or like I'm trying to have a conversation with you and you're shutting me down. No, I feel like I'm trying to be open and listening when you're coming out with these things. And I see that you're frustrated and I feel frustrated too. Doesn't allow for that defensiveness and refusal to happen because they don't have anything to defend. They're not, on the offense. They're really you're owning your stuff. But if that defensiveness is coming with like, yeah, that person's about to have a really big physical issue, like go. They're probably going to thank you later and apologize for being so defensive in those situations. Um, Thank you, Kirsten. I appreciate that. How are there ways that we can promote nutritionally dense foods while avoiding good, bad views of foods? Um, we can have a larger variety at home. So we can also start eating. We can also say like, hey, if you're going to eat those Cheetos, can we kind of have like a Cheeto and fruit breakfast? Or can we do other things? We also need to teach that teenager, again, not push it, but this is also why we have dietitians. So when we have somebody who needs to change their balance of food, the dietitian will also be a way to help that. They can kind of ease in other forms of how to sort of introduce other foods, how to change or how to add things that might actually be appealing in sort of the land of fruits and vegetables. There is, again, a certain amount of teenage junk food eating that I think we all engage in. But again, we can also limit that. If you're going to have ramen, then can you pick out two other things to put on that ramen, such as like some vegetables or other things or some protein, so that you don't have to just eat that ramen packet by itself? Could that be what we do? And also modeling that we're not just going to say it for other people to do, we're going to do it. Or then we just stop, kind of, again, only buying the Cheetos and ramen. We buy the things that are accessible. And we, model that. So I would say try as much as you can. If it really becomes something that we can't, then get a dietitian involved. They have a bunch of tips and tricks that we can do better. So you work in a health clinic where you have to take patients' weights every time they come. So you can actually go and look at some of the stuff on weights. There are some good articles by Jennifer Guadani, who wrote a book called Sick Enough. She is the director of the Guadani Clinic in Colorado, Denver, Colorado. She used to be the medical director of Denver Acute, which takes the most acute patients pretty much in the States and I think around the world. They see people and start with people at very low BMIs. And what I mean very low BMIs, I mean they take as low as 10 BMI. And if you can imagine what that looks like, that's pretty severe. It actually acts as a, eating disorder ICU. And some of her, articles that she's written and other things that she has been able to produce does give a good amount of information on that. If you go to the Academy of Eating Disorders too, which will also be on the list, there is actually a good little medical provider eating disorder resource kit. And if you have to take patients' weights, you can also ask them to take them blindly. If they don't prefer to know their weight, then great. If they refuse, they can refuse. It's their medical need. You can't force anybody to take their weight. You can't stop them from getting medical treatment if they don't have their weight, and unless it is something where that medical weight has a medical reason and that doctor needs to state what that medical reason is. And it can't just be, based on like physical overall health. Usually when we give those cards, and those cards are on that free resource handout that you can get, you can have somebody, use those, or you can talk about like, do we need to share weights with people, or can we talk about on a continuum, or can we do something else that if we feel like this is a person who is coming in and has a history of an eating disorder, they may know that they have to take their weight. Somebody who is pregnant, we have to take their weight. We have to talk about those things, but do we need to with every adult? Probably not. But it really is up to that person to that patient that if they don't want to, they don't want to. And they, even if you have to take it, they don't need to know it. So you can always have those cards available. And Wanda, you're not alone in it. It's, I would say, I don't fault, like your question is like, this has been just wow, household has been contributing to it. Honestly, um, I never fault anybody because you're doing the best with what you got. Now they have the information and what you can do different. Like it's your choice whether to change it or not. Um, I think in part, now you're even seeing the pediatrician neurologists have been contributing to this. Yes, have the conversations. If they do need to talk about weight for your kid, talk with you separately about it. Again, weight stigma and weight bias is a big thing. We need to be sure that we are making a conscientious effort of, you saw my production assistants. Um, Thank you so much, Ruby and Steve's, that they are doing their due diligence. You can share this with her therapist. I would kind of want to talk with the kid themselves. Like, do they feel this is an issue? Have they shared it with their therapist? My rule of logic and way that I look is like the kid's my patient and I'm going to be the most open with them. I will share with you, but if you share something with me, I'm probably going to tell your kid. So there's no secret keeping. There's no, I'm going to tell you this, but please don't tell them. So I would actually have a conversation with your kid like, hey, do you think this is something that maybe would be worth talking to your therapist together about? Or are you mentioning like, does this bother you? And what can we do? And that can easily be solvable. Yeah. Yes, the cards will be on the handout. You can buy as many as you want. You can download a couple. They're free resources. It's a very good service, and I think it's just one of the little small things that we can do. Are there any resources locally that treat eating disorders? What you can do is look in a couple of different places. So at the Association for Eating Disorder Professionals, you can look and see if there's any providers in your area, along with dietitians. You can also look at the National Alliance of Eating Disorders. They have the largest growing list of providers who are eating disorder specialists, along with insurances and other things that they can provide. There are other free resources besides that you can do. Nutrition Hive, along with Project Heal, which are both on there, offer free meal support for people who struggle with eating disorders. And you can sign up for every single meal that you would have in a given week or a couple. And doing some of those things. There can be very successful treatment over telehealth with a certified provider. So it doesn't always mean having to go to an emergency room and getting sent out of town. You can do a lot with the resources that are available. Again, we know that people do not have fully so much access, at least in the eating disorder world. We've known this for decades. A way that I can sort of like illustrate this even more is when I first started on inpatient units and in residentials, people were taking third, fourth, fifth mortgages out on their houses to pay for treatment for their kids because it wasn't recognized as a mental health disorder or being treated as a behavioral disorder. Like that's how much we had to fight for this. So there's a large majority of good free resources for anybody to be able to use that is quick and accessible. And we know the stats on even telehealth. There's people that I'm treating right now as a psychologist that are in Georgia, in Utah, in Tennessee, and their treatment is still very successful. So there's even fully online wraparound resources through different services called Equip. That is a virtual service that can help. So there is a lot of things that you can do to get it. And so we always don't have to go to the emergency room because again, that's one of the places where we can see people just like go eat a sandwich. Why can't you just eat? Duh, didn't figure that out. Like it's the most insulting thing in the world. And I've had it out with many ER providers of like, why did we say that? So yeah, there is a lot of stuff that you'll be getting that hopefully can help you kind of on your journey and explore it, show other people. It's a lot of good stuff. I answered all the questions. I won! Yay!
And those handouts that Dr. Terada was talking about, I will send out in an email following this
Yes.
webinar.
All right.
Thank you so much again. It was
Oh,
great.
anytime. I love doing this stuff.
And do you mind if I share your contact information with those that
No,
were here
go
tonight?
ahead.
Okay,
Go ahead.
I would
I'm
be happy.
always willing and open to, sometimes those questions pop up later, always open to answering them later. Or if other stuff comes up, I'm always a resource.
Okay. Thank you so much for everything tonight, and thank you all for your time. I hope you have a
Yeah,
good evening.
you too.
Thank
Hey,
you. Bye.
bye-bye.